This is HealthCall Online, the place for extended versions of interviews you hear on our weekly radio broadcast, the HealthCall Radio Hour. So our focus today is something that I think many Americans can agree on, and that is how we pay for healthcare in America is just broken. The system is sort of a mess. You know, it has been said that America's healthcare system really doesn't produce health. It really doesn't care, and it's really not a system. How do we get to a place where if you are sick enough to lose your job, you're also at risk of losing healthcare just when you need it most? Or if you fight to raise yourself out of poverty, you put yourself at risk of losing access to Medicaid. Yeah, so it is kind of a mess. And there's a new book that takes a look at what might be a solution. It's called We've Got You Covered. And one of the authors is with us today. She is Amy Finkelstein, an economist. She is an economist and a professor at MIT. She's also a member of the National Academy of Sciences, the Institute of Medicine, and a fellow of the American Academy of Arts and Sciences, and also of the Econometric Society. So, Amy, I'm glad that you are here.
Thanks so much for having me on, Lee.
You bet. So we're going to spend a fair amount of time today talking about the fix, what might be an answer to all of this. But I want to start out with something that's kind of a surprising fact that is pointed out in your book, and that is fixing the healthcare system is no guarantee that we're going to be a healthier nation. Why is that?
Yeah, that's a great point. I think one of the points that Laurent Einev, my co-author, and I make at the beginning of the book is that before we can start talking about what is the solution, we need to start by defining the goal, the objective. What is it that we're trying to do with health insurance reform? And while it's natural and many people think, one reason we should reform or expand health insurance coverage is to improve people's health, it turns out that health insurance is not a major driver of population health, and that health insurance reform is not going to be the lever to lean on if you're concerned about the dramatic health disparities that exist in the United States, the sort of 15-year difference in life expectancy between a 40-year-old man at the top versus the bottom of the income distribution, or the very, very disturbing racial disparities in health. So why is that? Let me first tell you why we're pretty sure that's right, and then we can tell you what we think is going on. So
Sure.
There's a lot of evidence, mostly not evidence we've produced, but going back decades, making the point that the major drivers of health are not the medical care you receive or the health insurance that can improve access to that medical care, but rather are factors related to the environment you live in, the air you breathe, the violence you are or not exposed to, as well as internal factors related to your own health behaviors, the cigarettes you do or do not smoke, the exercise you do or do not undertake, the caloric food you do or do not eat. Mm-hmm. And that there are many pieces of evidence for that. I think for us, one of the most striking pieces of evidence comes from work that colleagues of ours have done. This is looking at health disparities in other countries like Norway or Sweden, which have not only universal health insurance coverage, but really an extensive cradle-to-the-grave social safety net that's much more extensive than what we have in the United States. And even there, they document these enormous differences in life expectancy between people at the bottom and the top of the income distribution in countries like Norway and Sweden that are similar in magnitude to what we see in the United States. So the fact that you're seeing these enormous differences in health outcomes by income, even in countries that have universal health insurance and extensive social safety nets, is, I think, one of the clearest pieces of evidence that the primary drivers of health, or the primary levers to reduce health disparities, are not really about medical care or health insurance. So that's the evidence. Yeah. What's the explanation? Or put a little more bluntly, what are we smoking? How can we be saying that medical care is not important for health? That's not what we're saying at all. And in fact, the explanation relates to another key point we make in our book, which is that even in a country like the United States, which famously, as you said, is the only high-income country without universal health insurance, no one is literally uninsured when it comes to their medical care. So it's not that medical care is unimportant for health. Of course it is. It's more that, despite the many real problems that exist in our healthcare system, and despite the evidence, some of which my co-author and I have produced, showing that, yes, formal health insurance actually is really beneficial if you're uninsured. It reduces your exposure to major financial risk. It improves various measures of physical and mental health. But yet, in the grand scheme of things, people who are uninsured are not literally uninsured. For example, we've estimated that they get about 4/5 as much medical care as they would get if they had insurance, and yet they only pay about 20 cents on the dollar for that medical care. If they were actually uninsured, they would pay for all the medical care they got. So part of the reason that health insurance reform is not the key lever for improving population health is simply because even absent an adequate health insurance system, as you noted at the outset, we still no one is literally uninsured. We still come in and effectively provide or ineffectively provide most of the essential medical care that people need, even if they lack the resources to pay it. And that gets fundamentally to what we figured out in the course of writing this book is the fundamental purpose of health insurance reform, to recognize that we do that and to do it sensibly.
So one of the things that I think it might be helpful to understand is how we got to a place where your health insurance is tied to your job. How did all of that begin?
2 words: historical accident. There is no sense in which a bunch of wise men sat down and decided that the most sensible way to provide health insurance was through the workplace and let's set it up. Rather, as we discuss in the book, it arose as a historical accident that during World War II, the government imposed wage and price controls in an effort to deal with, shortages in labor when many people were off fighting in the war. Employers, as always, needed to find creative ways within the law to attract and retain employees. And so one thing they noted is that while price controls had been put on wages, benefits were not being capped. And so they started offering health insurance as a way to improve the compensation package for prospective employees without violating the law. Shortly after World War II, this was actually codified into the tax code, making the Internal Revenue Service ruled that such benefits, like non-wage benefits like health insurance, weren't subject to income tax. So in other words, if I'm your employer and I give you $1 of wages, you have to pay tax on that. Your take-home pay is going to be less than $1. However, if I pay $1 towards your health insurance premiums, you get that full $1 towards your health insurance premiums. It's not subject to income tax. And so that tax loophole or tax subsidy, which has grown to be $300 billion a year in tax expenditures, is the primary reason why we have this, I think largely unpalatable situation of most private health insurance being tied to the workplace.
Yeah, and as I indicated there, the big challenge is that ties you to a job that you may not like, you may not find rewarding. It puts you at great risk if you get so sick you can't work and then you lose coverage. I mean, that whole situation really is kind of a mess. When we look around the world, let me back up a second. So let's paint this picture a little bit differently. If this were a house that we're living in that has been updated and patched and fixed a million different times, suddenly it's not uncomfortable anymore. You come to a key point, right? You have to decide, do I tear it down or do I continue to remodel? Are we at the tear down state with our healthcare system?
Absolutely. In fact, we wanted the title of our book to be Tear Down, but we were told that was too dismal and we needed to be more uplifting. But yes, it's fundamentally a tear down. And part of the reason was, to continue that housing analogy, it was never designed and deliberately constructed. So it's not like, at one point we sat down and consciously designed a health insurance system that maybe was right, in 1965, and then now things have changed and we need to do some renovation. Rather, it emerged haphazardly over the last 50, 70 years as different issues became particularly salient, either because there was an infectious disease epidemic, like a tuberculosis epidemic, or more recently COVID, or a particular medical technology was developed that was life-saving but unaffordable, or a particular group gained, saliency, and issues were thrust before Congress, and patch by patch another program was put in place. So we have a series of health insurance programs that cover people with specific diseases. So a different program if you have end-stage renal disease or tuberculosis or Lou Gehrig's disease, or breast cancer, the list goes on and on. Different programs to cover people if they're sufficiently poor or sufficiently old or disabled. But all of these patches that were put on in response to particular political issues that emerged themselves fall far short of accomplishing their goals, because whenever you have a series of patches, there are always going to be gaps at the seams. Mm-hmm. Some of those gaps are the ones you alluded to already, that people can lose coverage because they no longer fit their particular eligibility requirement. And this is really perverse, that health insurance, whose very purpose is to provide a measure of economic security in an uncertain world, is itself highly uncertain. So as we document in the book, most attention focuses on the, say 1 in 10 Americans under 65 who are uninsured at any given moment in time. But in fact, a much higher share of Americans, 1 in 4 Americans, will have some period of time without health insurance coverage over a 2-year period. And that period of time is often substantial. It can be, 5-6 months. And that's because of all these different routes to eligibility. So you mentioned the example of, if you get insurance through your employer and then you lose your job or change your job, maybe because you fell sick or maybe for other reasons, you can lose your insurance coverage. If you're covered by one of these many public programs I mentioned, you can lose your coverage because your income changes, your age changes, you move states, or in the case of these many, many disease-specific coverages, really, I think quite perversely, if you get better, that's wonderful. You're now in remission for your cancer, but then you've lost your coverage because you qualified because you had, say, breast cancer. So this is just, and our experience with this patchwork approach shows why further patches, or to continue your analogy, renovations are just not going to cut it. It would be very tempting to say, let's just expand coverage for the remaining people who aren't eligible. Let's fix a few other, problems with the system. That's so much easier than to tear down and rebuild. The problem is, that even if everyone is eligible for insurance, that doesn't mean everyone will be covered. When you have these many different programs and pathways to eligibility, what we find is that about 6 in 10 of people who are currently uninsured are in fact already eligible for free or heavily, heavily discounted coverage. They just don't have it because they don't realize they're eligible, or which program they're eligible for, or they couldn't assemble the documentation to show that they're eligible. And this is one that happens a lot and is coming up now a lot with the end of the public health emergency. If you're eligible because of a particular program, then periodically we have to make sure you still qualify for that program. And so then we send you every year or so additional paperwork to show you still meet the income requirement or the disease requirement or what have you. And if you don't realize you need to refill out that paperwork, or you fail to assemble all your documents, you can lose coverage even if you haven't lost your eligibility.
Crazy. It is crazy. I get it. We have to change. So you are suggesting that we need to get in sync with the rest of the world and come up with a basic program of healthcare coverage for everyone, and then another layer for those who may want it, can afford it, or need it, of additional care. So let's talk that through a second. Paint that picture for me. How is it going to look?
Yeah, I think the key to our proposal comes again to this: what is the problem we're trying to solve? And as the history of our patchwork attempt that we describe in the book makes clear, the problem that we've been fundamentally trying to address is an unwritten but very strong social commitment to provide access to essential medical care regardless of resources. Now, that may seem like a strange statement to make about a country that is the only high-income country without universal coverage, and that where we famously advocate, for the frontier spirit of independence and everyone pulling themselves up by their bootstraps. But as we go through in some detail in the book, the lack of universal health insurance coverage reflects our failure to fulfill our commitment, not its absence. That if you look at the history of all the programs that got created when people were dying because they couldn't afford dialysis for end-stage renal disease, and so a special program was created to provide coverage for people with end-stage renal disease, or when a little girl is unable to be cared for at home because the rules of her health insurance policy require that she be in an institution. President Reagan intervenes and changes that. All of these reflect this fundamental commitment to try to make sure that people have access to essential medical care. And in fact, that fact you open this discussion with, the fact that health insurance isn't actually that important to health, also reflects that commitment. The fact that even the uninsured get about 4/5 as much care as they would get if they were insured and pay for very little of it reflects a series of public programs that have been created to try, in the event of extreme illness, to provide care for people regardless of whether they have insurance and can afford it. So once we recognize that we always have and always will attempt to provide essential medical care for individuals who need it, regardless of their resources, then it seems absurdly obvious and perhaps too simple a point, to write a book about, but someone had to do it, that we might as well formalize and fund that commitment up front through automatic basic coverage. And as we talk about, and I want to be very clear about this in the book, this is not only is this not a particularly new argument at some level, it's also not a argument drawn from one side or the other of the political spectrum. I think often when people hear universal coverage, they think progressives, liberals, this is a progressive agenda. But as we detail it a lot in the book, this argument for universal coverage as the most efficient way to make good on this social commitment to provide essential medical care regardless of resources has been acknowledged and embraced across the political spectrum, including very famous conservative intellectuals like the economist Frederick Hayek or the libertarian Charles Murray, as well as Republican Governor Mitt Romney, who this was the argument behind the first state to pass a mandate for coverage in the 21st century, Massachusetts.
So again, we're talking here about a system in which I don't have to apply or enroll. It's automatically available. It's not going to cost me anything for basic services. But how basic will those services be? Are we going to run into that slippery slope of, well, we'll add this, and now we're going to add that, and now this, and then that? I mean,
so I don't have a crystal ball to say, when our policy is enacted, whether we'll run into that slippery slope. I can say that the idea is for it to be actually quite basic. So it would provide essential medical care automatically and without any patient fees or copays, but with wait times that are longer than for non-urgent care than what people with private insurance typically experience. And perhaps less choice of doctor or ability to get any test you want than people with traditional Medicare currently experience. So in terms of the benefit package, it looks more like Medicaid, the public health insurance program for low-income individuals, but with the crucial ability that people who want more are able to supplement or top up. Whereas currently, if you're on Medicaid and you want to get to see a doctor faster than what you can through Medicaid, you can't just pay the doctor a little more. You have to go entirely outside the system.
Is the VA sort of a model that very close to what you're thinking of?
That's I think another quite reasonable model. To your question of would we get creep in the basic, that's in some sense up to us as a society. There's a minimum that's required. How much more generous we want to make the basic coverage, as opposed to saving that money for, say, lower taxes or spending on education or highways or what have you, that's a political decision. One thing we do insist on is that the basic coverage come with a budget now, right? So and then, we can vote as a society to raise that budget, but when there is, in any given year, there's a budget and decisions have to be made about what to cover and what not to fit in that budget. Now, that may sound And I think it is a bit banal. Like, what kind of program doesn't have a budget? On the other hand, when it
we
comes...
don't have a healthcare budget
Exactly.
as a nation today.
It's completely radical for healthcare. It's not how any other country functions. But yes, when we talk about, say, the Medicare budget, we don't actually mean the budget in the normal sense in which we talk about a budget in the sense of a budget constraint. Here's what you have to live within. Rather, we're speaking about what Medicare did happen to spend last year or what we project it will spend next year. With Medicare, the public health insurance program for the elderly and the disabled, there is no budget constraint. Anything that's covered, patients and their physicians can choose to get, and the government pays the bill. And if they choose to get more of it, those bills go up.
I can hear the squeals now of inequality. This is not fair. If I can't afford it, I'm stuck in some bare concrete block clinic as opposed to the hospital with a waterfall in the lobby. We're not going to get past that, right? I mean, it's just going to be two systems.
Yes, it will be two systems, but I will say, and it's very important, and we discuss in the book, that the key thing we're concerned about is that the adequacy of the basic system be maintained. And we talk about how other countries, basically every other high-income country, also has these two systems that, except for a few Canadian provinces and North Korea and Cuba, every country allows individuals to supplement the basic system. So it's unavoidable. It does raise real concerns about the adequacy of the basic system, how we, if enough people go into the supplemental system, will that erode either the financing of the basic system or political support for it, or just making sure there's enough high quality medical providers providing in the basic system. And we talk about how that's both a real issue, but a surmountable one that other countries have dealt with successfully through a combination of making sure funding is sufficient and putting in place regulations to make sure there's an adequate supply of physicians. And beyond that, our view is, to the extent you're concerned about inequality, and actually, personally, I'm very concerned about inequality, but the place to tackle that is not in the healthcare system, but in the overall tax system. If we want a more equal society, we need more progressive taxation. That's distinct from the question of how do we fulfill our commitments in the healthcare space in particular.
One of the things
sorry, go ahead.
I was going to say, one of the things that struck me in watching global news coverage of the COVID pandemic was how I saw in hospitals around the world, they're clean, they're tidy, they're neat, they're efficient, but they're basic. They're not as fancy as the hospitals here in the United States. And that really was driven home by, wow, okay, I can see one of the cost drivers in our system. That makes a lot of sense.
Yeah, but also, let's be clear, there's two dimensions of that. One is the quality of medical care provided, and the other is the non-medical amenities. And it's the latter that we think can be very basic. And I think that's what you were seeing when you were,
exactly.
And so we give the example of Singapore, which is one of the countries that has both a universal basic system and the ability to top up. And in the basic system, it's free to and automatic for everyone. If you go to the hospital, I think you're put in a typical room may have 10 beds. And in a notoriously hot and humid climate, their documentation refers to these rooms as being naturally ventilated. So that's a nice euphemism.
Okay.
But if as many people do, you buy supplemental coverage, you're going to still get the same surgery with the same physician, but then afterwards you can be wheeled into a private room with a private bath and air conditioning and high-speed internet and delicious food. Australia has a similar system. So again, our commitment, our social obligation is about essential medical care. It's not necessarily about all these other non-medical amenities, which are certainly nice to have. We give the example in the book to airplane travel. Like, sure, everyone would love free high-speed internet, tons of legroom, unlimited checked bags, but if we had a fundamental social contract to make sure that everyone could fly from point A to point B, you take one of those, low-budget European airplanes, right? It's not a wonderful experience. It's a little cramped, but they do get you safely from point A to point B. And then those who want can upgrade to business class or a different airline for a more deluxe experience.
So we need to set out and be clear that our goal is the equality of care, not the equality of the experience.
Yeah, I'd say it's the adequacy of care.
Okay, got it.
But yes.
Okay. What do you say
Say
to
to doc-
doctors who are going to look at this and say, this puts my entire livelihood at risk, and how is it fair that I'm going to spend the huge amount of money that is required to become an MD with an advanced specialization if my income is going to be restricted?
Yeah, I guess I'd say two things. One is, let's just go back to what we talked about a second ago, that, the concerns about inequality in a two-tier system. It's not at all clear that anyone's livelihood is going to be put at risk, in the sense, if anything, you could view this as an expansion of coverage. We estimate that about 2/3 of people would actually buy supplemental coverage. Basically anyone who currently has private insurance or the elderly. In some ways, our system is going to be much better. Even the basic system would be much better for them. They don't have the risk of losing coverage or having high medical bills that they have to pay themselves for their so-called covered care. But it would be a lot more basic in all the ways we talked about. So they'd buy supplemental. For people who are currently on Medicaid, the basic, as we said, is very similar to what they had, but they can supplement it. And for people who are uninsured, it's actually obviously much better. So I guess the first thing I'd say is, you can't have it both ways. Some people are worried that the system is going to create inequality, but to the extent it will entrench or not combat inequality, I don't think it necessarily has to have a first order detrimental effect on physicians and their income. The second thing I'd say is that any reform, and particularly a radical one like a teardown, is going to be disruptive. And, it's incumbent upon us to design a transition path that helps smooth that. And part of that, could be that, as is often done with policies, something is announced now and phased in gradually. So it's not like, you just got out of your 15 years of medical school and training, and now you suddenly have the system turned on a dime.
Is there a proposal, some legislation, anything that if I support this concept, I can get behind? Where does this go? What action can I, as a consumer, take to indicate, yeah, I like this idea, or I want to fight against it?
Well, first you should buy our book and make sure you read it thoroughly and make sure you like it. And then I think the short answer is that at a high level, what we're proposing is very similar to what every other high-income country has, with differences in the details. At a more specific level, I can't think of a single piece of legislation currently on the books that's exactly, or being proposed, it's exactly what we're proposing. But one can imagine tweaking various proposals or trying to institute this at the state level rather than the federal level. I'd say if you're interested in seeing this enacted, talk to people in policy or put us in touch with those people to discuss our proposal and how to translate it specifically into legislation.
Well, I have enjoyed this a great deal. There's so much more to discuss. We just scratched the surface. So I do encourage people to take a look at the book called We've Got You Covered, written by our guest today, co-written by our guest today, Amy Finkelstein. Thank you so much for being here.
Thank you so much for having me.